To secure a perfect Step 2 CK score on muscle pathologies, you have to absolutely master the exact physiological mechanisms and definitive board traps for inflammatory myopathies. So let's dive right into the high-yield diagnostics. Our agenda today covers 4 key areas. We're looking at true immunological myopathies, systemic inflammatory myalgias, drug-induced myopathies, and finally, central pain modulation. Section 1. True immunological myopathies. Let's break down the exact cellular mechanics because the boards love testing this difference. Polymyositis. Think of it as an inside job. It's a T-cell-driven, CD8-positive cytotoxic attack causing endomysial lymphocytic infiltration. Dermomyositis, on the other hand, is an antibody and complement-driven CD4-positive helper T-cell-mediated attack, and it targets the paramecium, leading to paramysial inflammation and perifascicular atrophy. Now, how do we anchor this diagnosis? First, you're looking for highly elevated creatine kinase, or CK, and aldolase. Once you see that, you've got to parse the autoantibodies. Anti-Jo1 is absolutely crucial. It screens for concurrent interstitial lung disease. Anti-Mi2 is highly specific for confirming dermatomyositis. And anti-SRP, that flags an immune-mediated necrotizing myopathy. When you spot these photosensitive markers on a patient, the diagnosis needs to instantly click. You'll see the classic heliotrope rash, that striking, violaceous periorbital edema. You'll also be looking for Gottron's papules. Those are the light pink to violaceous, scaly plaques directly over the metacarpal phalangeal and proximal interphalangeal joints. Here is your most critical takeaway for management. Diagnosing dermatomyositis isn't the finish line. It's the starting gun for a malignancy hunt. This is a major paraneoplastic syndrome. That means you must immediately screen for solid tumors, specifically ovarian, breast, lung, and prostate cancer. The risk of malignancy is strikingly high here, especially if TIF1 gamma antibodies are present. Let's lock this in with a classic clinical vignette. Imagine a 55-year-old female presenting with proximal muscle weakness and a violaceous periorbital rash. The cutaneous presentation has already clinched the specific myopathy subtype. So, what is your absolute next best step in management? Do not fall for the muscle biopsy trap. Since that visual diagnosis is absolute, you have to prioritize an immediate malignancy hunt. You need to choose a pelvic or transvaginal ultrasound or a screening chest CT. A muscle biopsy is strictly secondary when the clinical picture of dermatomyositis is already staring you right in the face. Moving to Section 2, systemic inflammatory myalgias, specifically focusing on polymyalgia rheumatica. For polymyalgia rheumatica, or PMR, you have to apply a very rigid clinical definition. This is exclusively a disease of patients over 50 years old. You're looking for profound bilateral pain and morning stiffness lasting strictly more than 45 minutes, and it's going to be localized directly to the shoulder and pelvic girdles. Now pay close attention because here is the ultimate Step 2 trap. PMR presents with completely normal muscle strength on manual resistive testing and a totally normal CK baseline. It's not a true myopathy. It's defined almost entirely by an ESR above 40 to 50 millimeters per hour, an elevated CRP, and, this is key, a near miraculous symptom resolution when you give them low-dose systemic corticosteroids, like 10 to 20 milligrams of prednisone. Let's see if you can navigate this. An elderly patient with severe shoulder stiffness displays normal motor strength and an isolated ESR of 65. What is your immediate next best step? The answer is administering low-dose prednisone immediately. You have to explicitly differentiate this from the high-dose steroid protocols. High-dose steroids are strictly reserved for patients exhibiting the visual or cranial symptoms of giant cell arteritis. If they don't have those, stick to the low dose. Section 3. Drug-induced myopathies. Let's explore the most highly tested iatrogenic pathologies. You need a razor-sharp clinical branch to separate the two most common culprits here. Statin toxicity gives you symmetric proximal pain, cramping, and a significantly elevated CK. The management? Stop the statin immediately. Glucocorticoid myopathy, however, is driven by direct catabolic effects on type 2 muscle fibers. It presents as painless, progressive weakness, and functional atrophy, but with completely normal CK, ESR, and CRP markers. Let's test this clinical branch with a tricky but very common scenario. You have a chronic COPD patient on daily high-dose prednisone. They also take a statin. Now, they're complaining of progressive difficulty rising from a chair. Their lab parameters show a completely normal CK and completely normal inflammatory markers. So, what's the diagnosis? You've got to trust the labs here. That completely normal CK proves this is glucocorticoid-induced type 2 muscle fiber catabolism. The classic board trap is throwing in the statin as a distractor, so you'll incorrectly choose to stop it. Don't fall for it. The statin isn't the problem here. Section 4. Central pain modulation. Let's lock down fibromyalgia. This is strictly a widespread soft tissue pain disorder, a central processing defect. You're looking for chronic, diffuse musculoskeletal pain lasting over 3 months, structural point tenderness clusters, sleep disturbances, and severe fatigue. But crucially, you will see entirely normal inflammatory and muscle enzyme laboratories. You differentiate the central sensitization from true myopathy by verifying the absolute absence of objective peripheral joint or muscle inflammation on your physical exam and your labs. Because of this, fibromyalgia requires exercise, SNRIs, or TCAs. This is diametrically opposed to the heavy immunosuppression required for organic peripheral inflammation. Finally, watch out for this definitive board pivot. You have an elderly patient with what looks like polymyositis, but it completely fails to respond to immunosuppression. This is inclusion body myositis. It's a neurodegenerative pathology, not just an inflammatory one, presenting with prominent weakness of the finger flexors and quadriceps. If it mimics an immune attack but completely ignores immune therapies, you have to pivot immediately. And honestly, it begs a massive question for the future of medicine. Are we fundamentally misunderstanding how muscle degeneration actually begins? Keep that in mind as you tackle these cases.